Next paper is a new model for predicting malignancy in patients with intraductal papillary mucinous neoplasm, presented by Dr. Shimizu.
Thank you very much, Chairperson and APA and JPS organized committee for giving me a chance to speak here today. Today's my topic is a new model for predicting malignancy in patients with IPMN. I have no COI to disclose. We previously created a cancer prediction nomogram in patients with IPMN and reported utility. This model is based on 4 predictive factors: gender, region type, and numeral nodal size, and pancreas cytology. Subsequently, we also report the usefulness of this model in the external 180 rejected cases and follow-up cases. However, this model includes region type and pancreas cytology. Pancreas is obtained during ERCP, and cytological diagnosis is indeed difficult. And region type definition has changed with time. In 2012 guideline, mixed IPMN are defined in addition to the MD and BD IPMN. For this reason, this model was not widely applied in daily practice. In 2013, we also report the predictor of malignancy in 310 patients with IPMN who underwent surgery at 3 hospitals between 1996 and March 2011. In this study, multivariate analysis reveals mural nodal size, MPD diameter, and cyst size are independent significant predictive factors. The aim of this study is to creating a simple objective model to predict malignant IPMN that can be easily applied in daily practice and importantly adapted for any region type. Study population were 466 patients with IPMN who underwent surgery at Aichi Cancer Center Hospital, Wakayama Medical University, and Teineki Ijikai Hospital. 310 patients underwent surgery between 1996 and March 2011. The data of this cohort were previously reported. And 156 patients underwent surgery between April 2011 and 2014. The investigation of predictor of malignancy was done for 10 factors of preoperative laboratory image finding. 10 factors of age, gender, symptom, serum amylase, CA, CA99 level, tumor location, mural nodal size, MPD diameter, and cyst size of branch pancreatic duct. In preoperative examination, EUS and CT are considered to be essential for all patients. The size of any mural node was determined by EUS. MPD diameter and cyst size, CT measurement value were used. According to the WHO 2010 histological classification and Baltimore consensus meeting, pathological diagnosis was classified as IPM is low or high-grade dysplasia or invasive carcinoma. All patients are categorized as benign or malignant on the basis of pathological diagnosis after resection. External validation population was 664 patients with IPMN who underwent surgery at 8 hospitals between 1996 and 2014. This study was supported by Japan Pancreatic Society, and these 8 hospitals was selected by the working group of JPS. Patient background and laboratory data and image findings and pathological diagnosis is almost same in the model development set and the external validation set. Factor associated with malignant IPMN by univariate analysis. 3 factors mirror nodal size, MPD diameter, cyst size are selected to construct the prediction model. They previously reported as a significant factor in the study of cohort 1, and they are reconfirming cohort 2 in the present studies. Taking account the guideline and clinical practice, 3 factors divided into 3 over 4 groups. Mural nodule were divided into 3 groups. If less than 5 millimeter was defined as reference, odds ratio are 2.93 and 7.90 for the 2 other groups. MPD diameter divided into 4 groups with less than 3 millimeter as reference. Odds ratio are 1.27 and 2.63 and 2.73 for the 3 other groups respectively. Cysti divided into 3 groups. When less than 30 millimeter as reference, odds ratio are 1.59 and 2.63 respectively. A score for each category was defined as 10 times value of the odds ratio. Malignancy prediction ability of the sum of the score correspond to AUC of 0.76 in the entire model development set. For the subset of MD, mixed BD-IPMN, AUC of the model was 0.71, 0.73, and 0.79 respectively. External validation of the models. AUC of the model were 0.72 in the entire external validation set. For the subset of MD, mixed BD-IPMN, AUC of the model were 0.71 and 0.68 and 0.77 respectively. A total score and cancer probability shown in this table. If patient with a total score of 52 to 65 were to undergo surgery, then this model would predict 47% of them the malignant IPMN, while 53% benign IPMN. This model shows the cancer probability with concrete numerical value in each individual cases. It's very useful to decide the treatment strategy depending on the patient ages and general conditions. Previous report. There are few reports of malignancy prediction nomogram in patients with IPMN. 2013, Memorial Sloan Kettering Cancer Center group report 2 nomogram in patients with BD-IPMN and MD-IPMN respectively. They are modeled based on 3 and 4 predictive factors, including body weight loss and history of malignant disease. In the study, all mixed IPM patients grouped with MD-IPMN. In 2017, nomogram for predicting malignant BD-IPM in large series of Korea and Japan was published. They are modeled based on 6 predictive factors, and the logarithm is used in the nomogram, so calculator is necessary for clinical practice. And in the study, BD-IPMN defined the MP diameter smaller than 10 millimeter. So some cases of mixed IPMN under current guideline were included as subject. As you know, according to the current guideline, more than half patients classified as mixed IPMN. However, there are no consistent data as to whether mixed IPMN, especially MPD diameter 5 to 10 millimeter, should be treated as a BD-IPMN or MD-IPMN. This fact sometimes there is a confusion in the clinical practice. In order to solve this problem, we create a simple objective model that can be easily applied daily practice and importantly appropriate for any region type. We hope this model would be applied widely in the clinical practice. It's my conclusion. This model provides important information for physician and patient and may help identify patients who need surgery. Thank you for your kind attention.
Questions? So at a time when I think a lot of a lot of groups are working to increase the granularity of data to apply to decision-making. You're trying to reduce the number of factors that we evaluate. It looked to me as if you had eliminated jaundice and weight loss from the nomogram. Is that correct?
Sorry?
Are jaundice and weight loss included?
Oh, no.
Which for us seems like a big, kind of a big loss, because I think that there are times when we really feel like those are compelling factors for us to further pursue at least, cytologic sampling, for example.
Yes.
Did you exclude them? It seems like it's not difficult to include them since you're including other clinical factors.
Yes. We checked the 10 clinical factors. So we don't have enough data for about the body weight loss and patient history. So we can't compare the diagnosis ability with the previous study. So
Because it wasn't routinely recorded in the
yes.
records. Mm-hmm.
Great, thank you very much.
Thank you.
Great paper.